everyone, my name is Amin Truhali and I'm doing this presentation for University of Kentucky Nursing School for class of nursing for 53. As you see, my practicum area was wound care. My practicum site was wound care nursing department at the University of Kentucky. This department oversees all hospitalized patients who have skin issues. There are currently 5 nurses and 1 manager in the department. What is wound care nursing? The wound care nurses, they basically go take care of all kind of skin issues. Unless if they are being in surgery, that will surgery department or dermatology department will take care of it. But nurses in wound care, they take care of pressure ulcer, MASD, or device-related pressure ulcer, any kind of wound that you can think of it, they are there to help treat and diagnose. The wound care nurses should have BSN degree, and they have to have 12 months vigorous education. After that, they have to sit for wound care certification. My learning objectives when I started, it was A, definition of moisture-associated skin damage, B, treatment of moisture-associated skin damage, C, understanding relation between moisture-associated skin damage and pressure ulcer. Also with that, I have, after understanding relation between MASD and pressure ulcer, I was more interested in what nurses can do to make it better. How did I meet my learning objectives? In a practicum set, I have hands-on experience with my preceptor. We have seen together multiple patients with MASD condition and pressure ulcer. And after we saw and we diagnose, we give the treatment, then we will follow up with same patients to see how our treatment worked or did not work, why it didn't work. So I have always, me and my preceptor, we always talk to the nurses about what can we make differences to change in the practice to help patients to get better. So as I said, MASD and pressure ulcer, they are 2 different conditions. Unfortunately, with the poor care, MASD quickly can turn into the pressure ulcer. This is picture of MASD as you see in gluteal. It's look pretty red, and this skin is very fragile. It seems like it's been sitting in urine such a long time, and it's become thin, and the pH change in the skin. So whenever the pressure is there, it will definitely going to open. When we open the skin, it's gonna get more and more. As we know, the skin open, they're very vulnerable to infection. So in my literature review, I have review a couple of them, but I'm going to talk about 2 of them that were important to me, which is David Vogeli explains what is MSD. MSD is prolonged exposure of patient's skin to perspiration, urine, feces, or wound the passage of irritants into the skin, leading to dermatitis. Those are incontinence-associated dermatitis, peristmal moisture-associated dermatitis, interregionous dermatitis, which is some patients have bigger breasts and they have skin folds in the same time. That can cause perspiration and then can open or irritate that skin area. It's called interregional dermatitis. The literature that I review supports and explains what I have witnessed in practicum area. Unfortunately, poor nursing care can deteriorate the conditions into the pressure ulcer or something else. Another literature that I review is in Journal of Nursing. It explains pressure ulcer and shows which factors can cause that. So we talk about MASD, and now we're going to talk about see how they explain pressure ulcer. So the pressure ulcer have intrinsic factors in PU. Among the risk factors involved age, weight, inactivity, urinary or fecal incontinence, reduced blood flow, low blood pressure, motor or sensory neuropathy, malnutrition, and psychological conditions. The extrinsic risk factors are pressure, friction, shear, moisture, positioning, and treatments with some type of drugs. So in here, we see that pressure ulcer, it says age, yes, definitely is important. Urinary and fecal incontinence, which is that MASD, right? Same time, the extrinsic factor is says moisture and shear. When there's a moisture, shear can happen. If you put the person in the same position, if it's sitting in a urine and feces, and that's what's going to happen, we're going to get pressure ulcer. It's very important to understand the connection between those two. And here there's two pictures. This is MASD and this is the pressure ulcer. So that condition can cause that. As the literature explained what can cause pressure ulcer, what I saw in my practicum site was MASD had a huge impact on pressure ulcer. Because when we have MASD and nurses or treatment doesn't work, if they stay long time in their feces or urine, and we cannot, or from wound, it could be from colostomy, the ostomy, and it's leaking, or from the wound is leaking all the time, and that can cause that too. So it's definitely whatever literature says, wound care nurses were following that. And best practice in wound care. In my practicum, wound care nursing did phenomenal job on diagnosing and treating MASD, such as educated nurses showing them importance of keeping wounds dry, turning them, and using specific equipment, such as Z-Flow. Is very important when patients have that, because they will not put the pressure on bony areas. And then whenever they have MASD, that will have to use some kind of treatment such as zinc, and keep them dry, and they will definitely prevent to get into the pressure ulcer. The wound care nurses follow literature very well. The experience that I have, that every nurse was responsible to read some new literature in a journal, and they were having regular weekly meeting, and they will go over that literature, which was very important and mind-blowing for me. They are very on top of the notch, and they have a meeting with follow-up with the managers if the patient does not get better in some kind of skin issues. They were trying to find where we can do better in nursing practice and to prevent the condition getting worse. So for me, I think they did really good job with that. But one thing that as a nurse at UK, I found some wound care nurses do not teach nurses. They just go and put the orders after seeing the patient. I think that for me, if the then wound care nurses come to me and tell me, hey, I found that, I'm going to treat with that, can you follow up, can you turn him, can you use this medicine every 2 hours or every 4 hours? That will stick better in my practice than just seeing orders, and sometimes even you can forget about them. Personal reflection in wound care practicum side was important to me because it made me a better nurse, a better bedside nurse, and I do understand terminology of wound care nursing now. And I do, when I see the skin conditions, I know which kind of treatment could be better and why. Why it is so important to follow wound care orders exactly. Now in my floor, I can help my patient, and at the same time, I can help other nurses to put it wound care nursing consult, or if there's not one available, I can give them some idea what could be working for their patients. Thank you.